Thank you very much. It's a pleasure to be here. It's always lovely to be in KL, and thank you very much for the invitation. Now, I'm going to talk really about, I guess, a class of drugs that many regard as old-fashioned, and some might even tell you probably shouldn't even be used anymore. And I hope by the end of this presentation you'll agree with me that there is still considerable place for sulphonylureas. Now, our chairman has actually told me already that my slide is out of date. This is 2006 data from Malaysia showing about a 15% prevalence of diabetes here, and I now hear it's gone up to 20%. So clearly it really is a big problem, and we know that diabetes is increasing dramatically in the region. Well, the objectives of good diabetes care, when we get down to basics, are to prevent microvascular complications, to prevent macrovascular complications, and to improve and maintain patient well-being. And I think that we know that with good glucose control, and we've heard from Mark's presentation just now, that we have very, very solid evidence that microvascular complications are reduced. Macrovascular disease, I think still we regard other things like statins, ACE inhibition, etc. as probably the key, with glucose control being important, but less so than those other things. And we do need to try to prevent microvascular complications. Here in Malaysia, the prevalence of diabetes in patients with end-stage renal failure is over 50%. So all of the countries in the region and other places like the US and New Zealand, Australia, you can see out of all the highest proportion of renal failure patients with diabetes is in Malaysia. So microvascular complications are very, very important. Now, what are the so-called experts tell us that we should do for diabetes treatment? This is the EASD ADA consensus algorithm that was revised in 2009. And you can see that the first thing that's recommended is lifestyle and metformin right from the time of diagnosis. And the evidence, I think most of us really probably wouldn't argue with that it seems to be a reasonable treatment in most people. I mean, we have to remember that the evidence for this is really based on absolutely pathetic data. The metformin group in the UK prospective diabetes study consisted of 342 patients, and pretty much the entire world's use of metformin, and certainly the enthusiasm for using it so early, is based largely on this cohort. Now, this may well be absolutely correct and would be the same in a much larger study, but it is interesting just how much weight, of course, we do put on metformin. And, of course, it has all sorts of other advantages, such as the weight benefits. And I think that in the studies lately where there's been follow-up of this, metformin does look as if it's an effective and safe agent for type 2 diabetes. It's also very cheap. Therefore, most guidelines have metformin as first line. But what about second line? Now, the algorithm really gives some choices as second line. It's, as you can see, lifestyle metformin, adding basal insulin. Personally, I think a stupid thing to be in early in diabetes, and I'll talk about that briefly a bit, but I see no place, personally, for early use of insulin in diabetes. If other treatments are effective. It then has lifestyle and metformin and sulphonylurea as an alternative to that, with newer treatments as a kind of alternative down the bottom as less well validated and, of course, much more expensive treatments. I think we've sort of come to the point where many people have really discounted sulphonylureas as useful treatments in diabetes, and there's a lot of push to use newer agents, GLP-1 analogues, DPP-4 inhibitors, glitazones, etc., much earlier in the course of diabetes. And I think we tend to forget that sulphonylureas really are pretty good and useful agents. There's a lot of misconceptions about sulphonylurea. Do they reduce diabetes complications? They're less effective than other alternative agents, many people say. there's a lot of talk about sulphonylureas exhausting beta cell. They drive the beta cell to produce a lot of insulin, and that fails earlier because of that. And there's also been concerns, and right back from the original UGDTP study, of adverse cardiac events with sulphonylureas. So let's just look a little bit about the evidence that either supports or refutes some of these things. Well, what about the reduction in diabetes complications? In the UK prospective diabetes study, and one of the wonderful things about this study was that there was an insulin arm right at the time of diagnosis. So we have really good evidence about what early insulin did. And you can see glibenclamide. These, of course, they used somewhat older sulphonylureas, chlorpropamide and glibenclamide. But you can see if you look at other diabetes endpoints, the yellow is the insulin, the green is the glibenclamide, blue chlorpropamide. It's absolutely clear that the sulphonylurea was absolutely as good, if not even, for at least earlier on, slightly better maybe, than insulin in reducing diabetes endpoints. So there is no question of efficacy in terms of reduction in complications in that study. And we know that complications were substantially reduced in the UK PDS, and with every percentage change in HbA1c, there were substantial reductions in microvascular disease. As you can see, a 37% reduction in microvascular, and some reductions in macrovascular, but not quite as significant. In a later follow-up of that study, and Mark alluded to this, for 10 years the patients were followed, and during that 10-year period, their HbA1c levels, which had been separated quite nicely by about 1 percentage point, the HbA1c levels came together. And yet, despite that, if we look at the endpoints at the end of that 10-year period, we can see that there's still this very robust reduction. Microvascular disease still reduced by 24% compared to the group that originally got placebo. Myocardial infarction becomes statistically highly significant, and all-cause mortality, not present at the end of the study, does become apparent. So evidence here that a trial in which a substantial number of the patients were taking sulphonylureas produced decreases in a number of endpoints, and those decreases have lasting legacy. Even if later the glycemic control advantage is lost, that good glycemic control continues for many years later, the so-called glucose memory effect. It's interesting talking about efficacy to see just how effective a sulphonylurea can be from the advanced study, and you can see that with glycoside, they managed to get 81% of the patients in that study to an HbA1c of less than 7%, which of course is the current target now in most guidelines. So really it is possible using a regimen based on sulphonylurea to achieve very good glycemic control in a large percentage of patients. So I think that it is clearly not true that sulphonylureas don't reduce complications. What about the efficacy? Are the newer agents, are other agents in fact better than sulphonylureas? Well, if we get back again to the UK prospective diabetes study, here is the effect of over time, and the HbA1c does drift off. So those of you that are treating patients and having difficulty controlling the glucose as you treat these patients for longer, you are in very good company. Expert centres have trouble controlling blood glucose as time goes on. And you can see that here, both the sulphonylureas, chlorpropamide and glibenclamide, indeed better than insulin in improving blood glucose over the first 4 years of the UK prospective diabetes study. And even the insulin-treated patients had this rise in HbA1c over time. It was no different with insulin and sulphonylureas. What about newer agents such as DPP-4 inhibitors? We don't have long-term data yet, but we certainly have some short-term data. And here's a study of 12 months looking at the comparison of a DPP-4 inhibitor, sitagliptin, with a sulphonylurea, in this case glipizide. And you can see an astonishing similarity between the efficacy of these two agents. This was on top of metformin, so following the sort of standardised guidelines, patients treated with metformin and then having an other agent added. The other thing I think that's important from this slide is that there is really no suggestion that there is any difference in the durability of glycemic control. So I'll talk in a moment about this sort of concept that the sulphonylurea is exhausting the beta cell, but there is no evidence here that the DPP-4 inhibitor is providing better longer-term control. As I said, it's only a one-year study, but the trend looks very, very similar for both drugs. Now, I think the issue of exhausting beta cells is a really interesting one, and it's certainly true that beta cells do become, if you want to use the word exhausted, over the course of diabetes. There certainly is beta cell failure. In fact, really, the reason that people get diabetes ultimately is because of beta cell failure. So people are insulin resistant, but early on in the piece, insulin secretion matches insulin resistance, and so the patient is non-diabetic. After a time, beta cell function starts to decline, and that decline in beta cell function is continuous, it's inexorable, and most patients, if they have diabetes for long enough, will ultimately end up with very poor beta cell function, be insulin deficient, and indeed require insulin for treatment. So is that really adversely affected by different treatments? And here is the UK prospective diabetes study. You can see metformin, the effect on HbA1c, as I've showed you before, drifting off with time. Insulin and sulphonylureas, and I showed you those separated in that previous slide. So here we're using a drug, metformin, which would be insulin sparing, beta cell sparing, if you like, resting the beta cell. No difference in the HbA1c over the long term in the UK PDS. And if we look at beta cell function using HOMA in the UK PDS, here's sulphonylurea. Obviously it goes up with the beta cell stimulatory effect, but you can see the rate of decline in the sulphonylurea group absolutely the same as metformin and as the same as those patients that were on conventional therapy. So resting the beta cell versus flogging the beta cell in the UK prospective diabetes study, absolutely no difference in the rate of beta cell decline. So do beta cells get exhausted? Yes. Is it due to hypersecretion of insulin? Well, the evidence to date would certainly point to no, that that's not the case, and certainly the UK PDS would tell us that no, sulphonylureas do not accelerate beta cell function. Now, what about the effects on the heart? This is a very important area and one that has caused people some concern. So the mechanism of action, or one of the mechanisms of action that's been proposed for this, is that sulphonylureas bind to the ATP-sensitive potassium channel in myocardium. And so this is the way that they work in the beta cell, but if they do that in the myocardium, you can impair ischemic preconditioning and certainly potentially cause problems, particularly in an ischemic heart. Now, there's no doubt that does occur with some sulphonylureas, but this effect differs with different sulphonylureas, and they have very different specificity on cardiac myocytes. So if we look at, and this is a study looking at myocardial infarction risk, and you can see that with older sulphonylureas in this particular study, there was a significant increase in the risk. With the newer sulphonylureas, glycoside and glibenclamide, there was no significant increase in risk with either drug. So there is a difference certainly between older sulphonylureas and newer sulphonylureas. And if we look at 30-day post-MI mortality, an area where this ischemic preconditioning in effect might be relevant, you can see that the white bar, the tolbutamide and glibenclamide, there is this increase in mortality post-MI, possibly related to this effect on the myocardial cells, that is not seen with the newer agents glimepiride and glycoside. Some of you would have been aware of this study that was published recently. This was a big general practice database study looking at the risk of cardiovascular disease and all-cause mortality depending on the sort of treatments that patients had received. They divided sulphonylureas into first generation, which was old ones, none of which we use now. And the second generation was glipizide, glimepiride, that we commonly use glibenclamide, and glycoside. So there was a mixture of agents that do and don't affect cardiac potassium channels in their analysis. What they were trying to do is to see if there was any association. They were all quite interested in looking at glitazones too in this particular study, but they were looking at myocardial infarction, heart failure and all-cause mortality, and it was a very large database, almost 100,000 people. So what did they find? Well, they found that both first and second generation sulphonylureas were significantly increased with all-cause mortality. The second generation better than first, but an 18 to 30% excess. Remember that they'd mixed the categories up in that second generation group, though. And quite interestingly, they found no association of MI with thiazolidinediones, including rosiglitazone. They did find decreased MI risk with pioglitazone. But my view is that their conclusions were probably completely wrong, or at least wrong in many respects. And there was a lot of problems with the study. I mean, one of the problems, certainly when we look at the sulphonylurea group, where they were about 5 years older, so it's not surprising that they would have higher mortality. They also had higher cardiovascular risk factors. There was a lot of difference in the way the different groups were treated. The group that had sulphonylureas tended to have much lower usage, interestingly, of statins and ACE inhibitors, sort of about 8 to 10% versus about 30% than the groups who had other treatment. And of course, we had glibenclamide mixed up with the newer agents as well. So we don't really know from this analysis whether if we use the agents that didn't affect cardiac muscle, we would have completely different effects. But it was really a flawed analysis, and I think little weight should be placed on it. There's another interesting study from a Scandinavian group from Denmark, and you can see here that sulphonylureas, compared to metformin, which was set as the baseline, sulphonylureas seemed to have a slight increase in their mortality hazard, but glycoside did not. In fact, it tended to go in the other direction, possibly related to the antioxidant effects. Again, I think one needs to take these database studies with a grain of salt, because we have acarbose turning out to be absolutely poisonous with a doubling, apparently, of risk. Now, I mean, why of the patients being put onto acarbose? Probably a lot of them had renal impairment, severe renal impairment, couldn't take metformin, given acarbose as an alternative. So really, these retrospective studies, I think, need to be taken looked at with great caution. Let's look at a prospective study. And Advance did, and it would be, as Mark said, it'll be very interesting to see what the Advance on data show, because at the end of the study, cardiovascular death was almost significant. There was a 12% reduction, and it just failed to reach statistical significance. Very similar sort of finding to what we saw in the UK PDS, and so, and of course that was a much longer study. So there seems to be a trend with glycoside towards a reduction in events in that particular setting. I think one of the other issues that's come up, and it does relate to drugs that can cause hypoglycemia, such as sulphonylureas, is can hypoglycemia relate and be a cause of increased mortality? Now, in the Veterans Administration trial that Mark spoke of, hypoglycemia was a strong predictor of cardiovascular death. In the ACCORD study, we know there was an increased death rate, although the analyses have suggested that they couldn't find an association with hypoglycemia. There was certainly quite a high rate of hypoglycemia in that study. And in the advanced study with dimicron MR, you had a much lower rate of hypoglycemia, and this trend to a reduction in events. The VADT study data was really very interesting. Severe hypoglycemia was related to, strongly related to cardiovascular risk. You can see if you had a severe hypo at any time during the study, there was a fourfold increased risk of death. Whereas things like, even a prior CV event only gave you a threefold increase. So it is a very, very strong predictor. And in that study, the intensive group had more than double the rate of hypos. You can see 188 versus 87 for standard control. Now, exactly the same thing was found in advance in terms of hypoglycemia being associated with death, and this is from the publication recently from Sophie Zongas that was in the New England Journal looking at hypoglycemia and the risk of death. And you can see, regardless of the modelling, you can see that with hypoglycemia, major macrovascular events, there is significantly increased hazard. Similarly for cardiovascular deaths, increased hazard. But hypoglycemia in that study was in fact really very low. You can see that in the intensive group there was 120 out of 5,500 that had an episode of hypoglycemia, and very low numbers having two or multiple episodes of hypoglycemia. So the rate per 100 persons per year in the intensive group, only 0.7. Now, there are differences in the rates of hypoglycemia between different sulphonylureas. I think it's interesting to look at this guide trial, which has made it into the NICE guidelines that have been released fairly recently. This was a trial looking at glimepiride and glycoside MR, and it's useful because, of course, these are both sulphonylureas which don't have adverse effects on the heart. So if you're going to use a sulphonylurea, you want to use one that doesn't have effects on the heart. Is there a difference?